Welcome to Advanced Practice, where we brew together the latest thinking in mental health practice. This content is for educational purposes only and does not constitute medical advice, diagnosis, or a prescription. Clinical decisions should be based on individual patient assessment and established professional guidelines. In this fourth installment, we move into the cutting edge of psychiatric pharmacology, the third-generation antipsychotics, or the dopamine stabilizers. But before we transition fully to the third generation, let's talk about the bridge. Lumateperone, brand name Caplyta, is officially classified as a second-generation antipsychotic, though it is often discussed as a bridge to the third generation due to its highly nuanced pharmacology. While it shares the serotonin 2A antagonism characteristics of all SGAs, its interaction with dopamine is unique. It acts as a postsynaptic antagonist and a presynaptic partial agonist at dopamine 2 receptors. This dual action approach, combined with its ability to indirectly modulate glutamate via dopamine 1 receptors and inhibit serotonin transporters, allows it to achieve antipsychotic efficacy at much lower D2 receptor occupancy of approximately 40% than traditional agents. Clinically, Caplyta is FDA approved for the treatment of schizophrenia, bipolar depression, and adjunctive treatment in major depressive disorder. One of its most significant clinical advantages is its simplified dosing. The standard therapeutic dose is 42 milligrams daily, taken with or without food, with no titration required. However, it is also available in 21 milligrams and 10.5 milligrams for specific reasons. But because of its low affinity for muscarinic and histaminergic receptors, Caplyta is recognized for a superior tolerability profile, specifically regarding weight gain, metabolic dysfunction, and extrapyramidal symptoms. Okay, now let's return to the third generations. While the first generation acted like a heavy-duty brake on dopamine and the second generation added serotonin-based buffer, the third generation introduces a far more sophisticated mechanism. These medications are known as partial agonists, and they represent a shift from simply blocking brain signals to fine-tuning them. The defining feature of third-generation antipsychotics is their ability to stabilize dopamine rather than just suppressing it. To understand this, it helps to imagine the dopamine receptor as a light switch. First and second generation drugs act like a piece of tape holding the switch in the off position. In contrast, third generation drugs like Aripiprazole, Brexpiprazole, and Cariprazine act like the dimmer switch. If there is too much dopamine activity, which causes hallucinations and delusions, these drugs turn the light down. However, if there is too little dopamine activity, which can cause the lack of motivation and emotional flatness seen in depression, these drugs can actually provide a small boost. This unique ability to modulate activity in both directions is why they are often called dopamine stabilizers. Because they do not completely block dopamine, third-generation medications generally carry a much lower risk of movement-related side effects and heavy sedation seen in older classes. They are also highly favored for being metabolic neutral. This makes them excellent candidates not just for schizophrenia and bipolar disorder, but also as powerful augmenting agents to help traditional antidepressants in patients with major depressive disorder. Choosing between the three main stabilizers often comes down to the specific symptoms a patient is facing. Aripiprazole is the pioneer of the group, known for being versatile. Clinically, it is FDA approved for schizophrenia, bipolar 1 disorder, manic and mixed episodes, adjunctive treatment for major depressive disorder, irritability associated with autistic disorder, and Tourette's disorder. For schizophrenia, the standard starting dose is 10 to 15 milligrams once daily with a therapeutic range of 10 to 30 milligrams. It is highly regarded for its favorable metabolic profile, showing minimal impact on weight gain, prolactin levels, or QTC intervals. However, its most notable clinical challenge is akathisia and its potential to cause impulse control disorders such as pathological gambling or compulsive eating. Aripiprazole is likewise available in long-acting injectable, which can be dosed monthly or once every 2 months. Brexpiprazole, brand name Rexulti, was developed to offer similar benefits as aripiprazole but with a slightly quieter profile. Often described as a serotonin dopamine activity modulator or SDAM, it possesses a lower intrinsic activity at the D2 receptor and more potent serotonin 1A agonism and serotonin 2A antagonism. This profile is engineered to provide antipsychotic efficacy with a significantly reduced risk of akathisia and restlessness. In clinical practice, Brexpiprazole is FDA approved for the treatment of schizophrenia as an adjunctive therapy for major depressive disorder and for the treatment of agitation associated with dementia due to Alzheimer's disease. Dosing for schizophrenia typically begins at 1 mg once daily on days 1 through 4, titrating to 2 mg on days 5 through 7, with a target maintenance dose of 2 to 4 mg daily. For adjunctive MDD, the titration is more conservative, starting at 0.5 mg or 1 mg and targeting 2 mg daily. Its metabolic profile is relatively favorable. Cariprazine, brand name Vraylar, is distinguished by its unique pharmacodynamic profile as a dopamine-preferring dopamine 2 and dopamine 3 partial agonist. While most agents in this class focus primarily on D2 receptors, Cariprazine's high affinity for the D3 receptor, which is involved in the regulation of mood, reward, and cognition, is theorized to contribute to its efficacy in treating the negative symptoms of schizophrenia, such as social withdrawal, lack of motivation, or anhedonia. Clinically, Cariprazine is FDA approved for the treatment of schizophrenia, acute manic or mixed episodes associated with bipolar I disorder, bipolar depression, and as an adjunctive treatment for major depressive disorder. For schizophrenia, dosing typically begins at 1.5 mg daily and can be titrated to a therapeutic range of 1.5 mg to 6 mg. In bipolar depression, the target dose is generally lower at 1.5 mg to 3 mg daily. While cariprazine is noted for its metabolic neutrality, the most common clinical challenge is dose-dependent akathisia, which may emerge several days or weeks into treatment due to the drug's extended titration curve. It has exceptionally long half-life, meaning the medication remains active in the body for a long period, which can be a safety net if a dose is occasionally missed. So there you have it, the 3 third-generation antipsychotics we have in the US market. But we have a postscript. This last drug is not an antipsychotic, but we will add them in this section. While not classified as a traditional antipsychotic due to its lack of direct dopamine 2 receptor antagonism, Cobenfy, which is xanomeline and trospium chloride, warrants inclusion in this series as it represents the first fundamentally new pharmacological approach to schizophrenia in over 50 years. Approved by the FDA in late 2024, Cobenfy functions as a first-in-class muscarinic agonist. It selectively targets M1 and M4 receptors in the central nervous system to modulate the circuits associated with both psychotic and cognitive symptoms. By bypassing the dopamine receptors that drive classic motor and endocrine side effects, it offers a novel pathway for patients who are sensitive to the EPS or metabolic burdens of traditional agents. The dual component design of Cobenfy is critical for its clinical profile. Xanomeline provides a therapeutic muscarinic activation in the brain, while trospium chloride, a peripherally restricted muscarinic antagonist, is included to mitigate the GI and autonomic side effects like nausea, vomiting, that limited earlier cholinergic research. For the treatment of schizophrenia in adults, Cobenfy's titration begins at 50/20 milligrams twice a day for at least 2 days, increasing to 100/20 BID for 5 days, with a maximum maintenance dose of 125/30 milligrams BID based on patient tolerability. Clinicians should prioritize monitoring for cholinergic and anticholinergic side effects. Okay, that's it for today. If you found this episode useful, please share it with colleagues across disciplines. Thanks for listening, and watch out for our series on drug-induced movement disorders as well as antidepressants. Until next time.